So I'd like to welcome everyone today to the Vasculitis Foundation's webinar. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series. I'm also a patient living with MPA vasculitis. And these webinars are part of the Vasculitis Foundation's commitment to patient education. And today's webinar is IgA vasculitis, formerly known as Henoch-Schönlein purpura or HSP, with Dr. Vidya Sevaraman. And after we finish this webinar today, there'll be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who's registered will receive an email with a link to it as soon as it becomes available. Let me begin by introducing our guest for today. Dr. Vidya Sevaraman is a pediatric rheumatologist at Nationwide Children's Hospital, associate professor of clinical pediatrics at The Ohio State University, and Director of Quality Improvement in Rheumatology. Her research interests include childhood vasculitis, scleroderma, and vaccination in immunocompromised children. She's a leader of the Chronic Childhood Vasculitis and Vaccination Work Groups in the Childhood Arthritis and Rheumatology Research Alliance, which is known as CARRA. And that's an international research network for pediatric rheumatologists. And she's also the co-author in multiple publications and treatment guidelines related to vasculitis in children. She's passionate about patient education and advocacy, and we're delighted to have her as the co-chair for the Vasculitis Foundation patient conferences and the annual National Children's Rare Disease Day event for patients and families. So thank you for all of that, Dr. Sevaraman, and thank you for being here today. And I'd like to ask you, just before you share your screen and start us today, I'd like to ask you if you have any disclosures.
I have none that are pertinent to this talk.
Okay, well, if you'd like to share your screen today, we would love to learn more about HSP.
Awesome. So I'm going to just share my screen, and you can tell me if you see that.
There it is.
All right. Well, thank you so much, Kathy and Jen and Ed and all the staff at the Vasculitis Foundation. I've really enjoyed working with you all in the past few years, and just thank you so much for all that you do, and particularly making the website and things that are such good resources for our patients and families. And thank you to everybody that's here today. So I was asked to talk about IgA vasculitis, which was formerly known as Henoch-Schönlein purpura or HSP. So if I refer to it as HSP, I'm referring to the same condition in case you see me refer to that, or some of the slides still have the old terminology. So again, this is primarily a pediatric disease, but I will try to highlight some of the manifestations that could occur in adults. And again, since I'm a pediatric rheumatologist, you might see more of it in the context of children. So let's start with some definitions, and some of this might overlap with other types of vasculitis in case you are familiar with those, or if it's pertinent to some of that. So some of the definitions, so just to start out, the word vasculitis, which I'm sure all of you are aware of, refers to inflammation in blood vessels, and that could be blood vessels of different sizes that are in our bodies. So the bigger vessels are called arteries that carry the good blood. The veins are the ones that carry the bad blood back to your heart. And then the capillaries are the tiny, tiny blood vessels that are usually either in the skin or different organs. And really what's common to all of these, no matter what exact vasculitis it is that they affect different organ systems. So as you can imagine, blood vessels are in every part of our body. So different types of vasculitis can affect different organ systems. So the skin, for example, the intestines, kidneys, or even lungs, or even the nervous system. And so based on the type of disease, we kind of see involvement of different parts of the body. And then what is common to all of these is that they are all considered autoimmune disorders. And what that means is that the body's natural immune system, or your natural defense system, starts to attack healthy tissue, which it's not supposed to do. So these are kind of just some terminology as ground rules that you'll see in the course of this talk. So I like this figure here because it breaks down the different types of vasculitis. And this is from way back in 2012, 2013. Some of you may have heard of in Chapel Hill, North Carolina, where they had a big conference where they decided about the name for a lot of these diseases. And a lot of the terminology was changed during that conference. And so here you could see different types of vasculitis that affect either the large blood vessels and then going down to medium and then small vessels. So if you can see here, I'm not sure if you see my pointer, but Henoch-Schönlein purpura or IgA vasculitis falls within the group of small vessel vasculitis. And then sometimes also we refer to it as immune complex, which means that there's immune deposition, which I will refer to later on in the talk. And so just again, with all the different types of vasculitis, and it can affect different organ systems. And so we won't go into this in detail, but this is just to give you an idea how it can affect different parts of the body. So let's start a little bit about IgA vasculitis. So first of all, how common is this condition? So we know overall in adults, for example, the annual incidence is about 2 per 100,000 population. But the majority of these, as I said, are in children. And so over 90% are in children ages 3 to 10. But even though we say, that this is a disease mainly in children, one thing that is important to keep in mind, just like other types of vasculitis, is that there can be severe disease and in some cases even death if the diagnosis is delayed. So they are pretty serious conditions, which is why you will see, doctors like me, like rheumatologists and different specialists that are often, we're very cautious when we talk about the term vasculitis, because it's definitely not something to be taken lightly. And so what do we know about what causes it? So just like many of our autoimmune diseases, we actually do not know the etiology. So we don't know exactly what causes it, but we have seen that it is more common in winter and spring months. And so we often think that there is some kind of an infection that could trigger it. For example, it's often seen after strep infection or even just upper respiratory or GI infections. Sometimes there are medications that can trigger it, or very rarely cancer may show up with a form of vasculitis like this. It's important also to know that this condition is not contagious, as is the case with other forms of vasculitis. So when you see the rashes, people might be afraid that it's contagious, but it's important to explain that it's not. So I'm going to start with a little patient case, and then we'll kind of go through the different symptoms. So this is a girl who's a 9-year-old girl who we're seeing in the emergency room. She comes in with this rash that you're seeing on the picture. You can also see that her ankles are a little swollen, and then she's complaining of some abdominal pain, and she's noted that her urine is a little bit dark. And all of this has been going on for about 3 days. And when we talk to her, we also find out that she had strep throat that she was treated for about 2 weeks ago. So, in starting to think about this, this could be a patient that comes into any, emergency room, whether it's a children's hospital or any kind of urgent care. And so as physicians, when we see something like this, we start thinking about what could be the potential causes. And so I'm going to talk you through just different conditions that we check for, because sometimes before you get an answer that it's vasculitis, you might, go through some of that testing. So on one hand, I tend to think of this as one of the first questions I think of in this case is if there's fever or if the child is ill appearing. So in a situation that a child might have fever or looks ill with this condition, immediately we start thinking about some pretty serious infections. So sepsis, for example, which is like a bacterial infection that's in the bloodstream. Meningococcal infection, which is the bacteria that causes the more typical bacterial meningitis. So these are very serious conditions that you cannot take lightly. And interestingly, it has a very similar type of rash. And so the minute we see that, these alarm bells are going off in the medical provider's head saying, is this something that I need to very urgently look at and evaluate? Another is with that abdominal pain, if it's more severe, oftentimes gets confused for different types of abdominal emergencies, like even appendicitis, for example. So we've had patients, for example, that get taken to the operating room because they're worried that this is appendicitis because of their belly pain. And then if the child is not having a fever and just sitting there but has this rash, we think about lots of different conditions. One that you might hear a lot about is lupus, which stands for systemic lupus erythematosus. So it's an autoimmune condition that does in many ways overlap with vasculitis, and it's often something we're ruling out in our patients before we diagnose them with vasculitis. And then all of the other subtypes of vasculitis that I will not go into are definitely also kind of on our list. And then we said that this girl had dark urine, and she had strep recently. So there is a form of kidney inflammation that can occur after strep infection. That's called post-streptococcal glomerulonephritis. So this is definitely something that would be on our list that we need to think about. And then the last one is one called hemolytic uremic syndrome, which actually can occur after like GI infections, E. coli, sometimes when you hear about like the different outbreaks in fast food restaurants and things like that. So those can kind of overlap with this condition too. So let's talk a little bit about what we think this trial has. So IgA vasculitis, also known as Henoch-Schönlein purpura, like I said before, is the most common form of vasculitis in children. The most common age is anywhere from 3 to 10 years of age. It often does happen after an infection, most oftenly strep. Typically, the entire course lasts just 3 to 4 weeks. So even though the rash can look scary, they can be in a fair amount of pain, but the disease typically just kind of runs its course and then it just goes away. So that's very different from all the other types of vasculitis, because this is not one that we think of as being a long-term condition like the other types of vasculitis. Now, it's also important to note that up to a third of children will have at least one recurrence. So even though they go through the entire course and they're doing well, a few weeks later, a few weeks or months later, they might have another outbreak of the rash. And so sometimes parents get worried that this is coming back. But typically those recurrences are better than the initial presentation. And so we have some diagnostic criteria. And so this is a very, very specific type of rash that we see that I showed you in the picture. We describe it as a raised red or purple rash, often resembling bruises. And the medical term for that is purpura, Purpura. And it's basically that purple color to it, but definitely kind of raised and bumpy and even bruised looking. So that's a very, very specific classic rash that you see in this condition. And then just varying degrees of joint complaints. So there could be pain, there could be swelling, usually in the ankles or knees. And the good news is this is not a long-term type of arthritis. So it goes away and not like arthritis that you're seeing with other autoimmune conditions. We will talk a little bit about the belly because that's probably one of the big complications that we worry about in this condition. So it can be anywhere ranging from belly pain, nausea, vomiting, blood in the stool when they go to the bathroom. So a different range of abdominal complaints. And then the other big organ we worry with this condition is the kidneys. And the inflammation in the kidneys is referred to as glomerulonephritis, which just means inflammation in the tiny filtration system of the kidney. And I'll be showing you that in just a few minutes. And then if you are in question of the diagnosis, we will often get a tiny piece of the skin, what we call a tiny punch biopsy. And there's a specific finding in that with deposition of this immune protein called IgA. And that's what gives it the name IgA vasculitis. So this is that rash that we were talking about. So very typical, and the rash I showed you before in the case. So it's bright red. I sometimes refer to it as bruises under the skin. And they could be either pinpoint or they could even start coming together. Sometimes, rarely it'll blister. And it's usually towards the back of the legs, more towards the buttocks, or even in the private area, in the underwear area, both for boys and girls. So there can definitely be a lot of inflammation with the skin, which is the number one symptom of this, and really the classic hallmark. Like if we see this picture, it's like a textbook description of this rash and this condition. And so we'll go through some of those complications in the next few slides. So the first big complication that I highlight, and we tell our students this all the time because this is something they need to kind of have at the tip of their fingers because they get asked this a lot on their tests. So the major complication of IgA vasculitis more early on is going to be with their intestines, with the abdominal tract. And so this is a picture showing you an ultrasound of the abdomen, which is what we often order if somebody comes in with severe abdominal pain and the typical rash. And what you see here basically looks like a circle, which is the bowel loop here on the left. And what happens is, if you think about it like a sock kind of going into, if you've got a sock that's kind of going inside out, and you have the part of the sock on the outside and part of the sock on the inside, that's exactly what's going on with the bowel loop. And so it starts out with swelling in the bowel as a result of vasculitis. And then when the bowel starts to do that, it causes a lot of cramping pain, which can be pretty significant. And then that can actually lead to a bowel obstruction. And then that can even cut off the blood flow to the intestines. So this is definitely a pretty scary complication. So we don't mess around with this if we're suspicious of this. And so that's what these two images show you is the ultrasound. And I do have some more pictures of the bowel. So if you feel like you're not, it's something that you want to avoid seeing, please, you can look away just for the next slide. But it's basically to show that damage that can happen in the bowel. And that's why we want to try and find it early so that we can prevent more like a surgical emergency in that case. And so this is on the left, you can see that inflammation within the bowel if somebody had to have surgery for this, where it's really bright red and the blood flow is increased and there's a lot of inflammation. And the panel on the right is basically showing you where it cuts off the blood flow to the bowel. And in that case, they actually have to remove a part of the bowel, a piece of the bowel, if that happens. So that's what we're really trying to prevent when we see these kids with severe abdominal pain. That's not something we take lightly. So we talked about the belly a little bit, and I will come into treatment in the next few slides, but I just wanted to kind of highlight that that's something that we really, really emphasize to all of our trainees and the doctors, that it's something they need to know about. Even if somebody goes in as an urgent care visit, that it's something that you don't want to miss. And then the second big complication is one that is actually more delayed. So it doesn't happen early on, but it's also something that's very important to know with this condition. And what that is the kidneys. So the kidney is the other major organ that gets affected with IgA vasculitis. And it's about a third of patients who get some amount of kidney inflammation. And like I mentioned before, the word for that is glomerulonephritis. It may not happen right at the time when everything's going on with the rash and the joint pain, but it usually does happen within the first 3 months. So may not be right there within those first few weeks, but it could be just a little bit delayed. And so what do we look for here? So the simplest test for that is actually a plain and simple urine test. We usually have the patient just give us a urine sample, and we're looking for either blood or protein in the urine. And the medical term for that is hematuria or proteinuria. The other big sign of kidney involvement is elevated blood pressure or hypertension. Very rarely can lead to kidney failure, which is usually, fortunately, less than 10%. And one important thing that I tell all of our trainees is that it's not enough to just do a kidney function. So if you just get a blood test to check your kidney function, that can be completely normal. So you cannot wait until that's affected to look for kidney disease, because it's going to show up much earlier if you do a urine test. So the urine test is actually the right answer of the way to monitor for this. And so actually, as a result, what we end up doing is that we actually do urine testing on these patients for up to 6 months after their initial diagnosis. And that's the reason for that, is that you want to make sure that you don't miss any sign of kidney disease and that we can refer them to our nephrology colleagues right away in case they need further testing or treatment. So let's come back to our patient now. So this is our 9-year-old girl that we were seeing. I showed you the typical rash. She has some swelling in her ankles. She's had belly pain and the dark urine. So now the doctor tells you that they're considering a diagnosis of IgA vasculitis. So the next couple slides, just let's go through really quick what kind of testing might be done, just for you to be aware that these are some tests that your doctor might be ordering. And it kind of relates to the other conditions that we said we would kind of exclude. So our first and foremost in all patients is going to be a very plain and simple blood count. So we do that complete blood count because something just as simple as a white blood cell count can tell us if it's high. Then we think about infections. We look for anemia because that could be a bad sign that there's some bleeding going on in their GI tract. And so these are important things. We also check the platelet count because if that is low, that can mean that there's a risk of bleeding. So just something as simple as a blood count can actually give us a lot of information. The second most important test, like I mentioned, was the urinalysis. And this is because we're looking for protein or blood in the urine. The third test might be an abdominal ultrasound if there was belly pain. And that is to look for that thickening in the bowel or any signs of obstruction or that condition I mentioned called intussusception. The next, your doctor might also order a stool test, and that would basically also be to look for any signs of blood that's being lost in the stool. And then in terms of other sophisticated blood tests, there really isn't a whole lot Like I mentioned at the top here, there is no diagnostic laboratory test, so it's really ruling out other things. The IgA, like I said, it's one of the main proteins that's affected in this condition, and so it might be elevated in the blood. And then all of our typical tests we do for, say, lupus or arthritis, or even other types of vasculitis, you might have heard of the test called ANCA. These are all going to be negative in these patients. So it's really not even necessary to do those tests. And so if you do other sophisticated immunology tests, sometimes we're doing other tests for lupus if we're worried based on the presentation. But all of this is going to be typically negative, and it's really more to rule those out as other important conditions. And so if this was a patient that needed a skin biopsy, this is just to show you what might happen there. So this is basically just a tiny piece of skin. It's literally just like you take like a hole punch. You have just like a little punch that they could take, and they do this right there in the office with our dermatologist. And this is not required for diagnosis, but typically we get this more in a patient that's either more severe or not responding to treatment. And so here on the left, you're seeing actually more of a normal skin. The part towards the top right corner is actually the top of the skin, where you might see like hair follicles and sweat glands and things. But then towards the inside, you're seeing those tiny little blood vessels, and the little blue and purple cells are some of the immune cells that are in the skin. On the other hand, in the one on the right, you can just see right away that if you see more purple, that means there's more inflammation, because those are some of those lymphocytes, the cells for inflammation. And then the dark pink that you're seeing is actually some of the blood cells that are coming out of the blood vessels. So you're basically seeing that vasculitis. So it just helps you sometimes to confirm the diagnosis of vasculitis, particularly if there's a doubt. Another test that we sometimes do is what's called immunofluorescence. So this panel on the left, the bright neon green, is basically a test that's called immunofluorescence, and it's just like a fluorescent dye that they can put and look at it under the microscope. And so you're seeing that fluorescent green, and that is, it can test for specific immune proteins. So in this case, it's the IgA. And so you're actually seeing that deposition of IgA in the skin. So this can be a pretty cool test that we can do, again, just in patients where there is a doubt of the diagnosis. So definitely not necessary, but can be done. Excuse me. All right, so in the next few slides, let's talk a little bit about treatment, and then we'll talk a little bit more specifically about adult disease. So in the majority of patients with IgA vasculitis, fortunately, the major treatment modality is really just supportive therapy. So that might just involve, drinking more fluids, just symptomatic therapy for pain. And the majority of patients don't even need any of our stronger medications. Even steroids may not be needed. Excuse me. And so which patients do we give steroids to? So it's actually pretty targeted to specific complications. So even though the rash can look pretty scary when it's happening, we don't really need to have steroids as part of that treatment. Excuse me. It's only indicated for the more of the complications. So the first complication that steroids are usually given for is the intestinal involvement. So in this case, if there's swelling in the intestine, or if there's any concern for hemorrhage, those would be patients that need steroid treatment. The second is any signs of kidney disease. And this is actually still pretty controversial. Excuse me. Excuse me 1 second. So sorry, I'm getting over a cold. And then the third one, actually in males, is they can actually get swelling in their testicles with inflammation, and that can be pretty painful. And so that's another indication where we might actually want to give steroids. As far as kidney inflammation, there is still a lot of controversy, and so I'll go through that in the next few slides. But additional immunosuppressive medications may be indicated in those patients. And like I mentioned before, the majority of patients just go through the entire course of the disease within about 4 weeks. And so 3 to 4 weeks, they may seem kind of miserable. They may have this rash that looks scary, but fortunately, it all goes away completely. It doesn't leave any kind of scars or any kind of long-term sequelae. So that's the good news there. And then, like I mentioned, about a third can have some kind of recurrence, usually the rash, and usually it's milder. So that's good news also. And very rarely they go into end-stage renal disease. Sorry, I didn't expand that, but that's basically more long-term kidney issues, but that's less than 5%, so that's good news. I like to include some of these little images in my slides just to kind of get people kind of back awake. Nowadays, just staring at a screen can get boring. So I like all these little optical illusions. With a lot of our rheumatology diseases are kind of like this. So, and people can either call out or whatever. I know in the interest of time, I may move on, but if people want to call out what you see, that's one option, or you can type it in the chat. So I know when I first look at this, I see a face, but if anybody sees something other than a face, maybe type it in the chat. So we can come back to it too. All right, so this is basically just a good example of what rheumatology is. A lot of times, we see the first thing, and we, as doctors, we sometimes, see the first thing and we make the thing that it's most likely to be. But then we're like, well, it's not exactly fitting the pattern. So are we missing something? I see somebody has typed something in the chat. Okay. Anyway, so we will see, the face. Yeah, I think the majority of us see the face, but if somebody sees anything other than the face, let me know.
I'm looking, I see a face.
Okay. Does anybody see a word?
Huh. I just don't. I can't wait for you to tell me what it is, so I know what it is.
It's liar.
Okay.
Liar.
Liar. There you go. Liar. So if you kind of look at it sideways, and then here you have the LIAR. You see it now? Yep. All right. So it's basically the word liar. So there. Yeah. Good job, Jen. Okay. So basically, a lot of our diseases are like this. And I'm sure some of you might have had a journey like this with your disease with vasculitis too, because we're often like second guessing ourselves. And we're kind of used to that in rheumatology because this is where we live. So let's move a little bit on to IgA vasculitis in adults. So as I mentioned, it is definitely less common in adults, and it's only about 0.1 to 1.8 per 100,000 individuals. There does seem to be another age peak, often around the age of 50. And here there is a chance of more severe disease, and it does seem like there may be a higher chance of kidney involvement, the glomerulonephritis. So again, very small number, but potentially there is a chance for more concerning disease. So it's going to be in some ways very similar. So again, here treatment might be very similar, where we might use steroids if they're having a lot of joint pain or arthritis or the severe abdominal pain. But here we might actually have a few other treatments. And so I'll kind of highlight that in the next few slides. And there have been just a few studies, so I'll kind of point those out also for you. So one medication that some of you might have heard about if you've had other forms of vasculitis is called mycophenolate, and we sometimes refer to it as MMF or mycophenolate mofetil. So this is a pill that's given twice a day, and we use it for lupus and vasculitis. Lots of kidney patients are on this medication because it works very well for kidney diseases. So this is one that you will often encounter in this situation. And then we do have a small number of patients where the skin disease actually almost takes on a life of its own, and it's really, really hard to control, particularly if they're having like blistering in the skin or ulceration. And that can be pretty annoying and cumbersome for quality of life. I've had some patients where, you wean the steroid and then right away the rash comes back. So in that situation, we start thinking about a few other treatments. And the reason for that is that steroids, while they're very effective, they're not good long-term medicines. So while you might know this from all of our diseases, when we use steroids, they're very effective in the short term, but they definitely have a lot of long-term side effects, whether it's weight gain or acne or sleep issues, thinning the bones like osteoporosis, cataracts, and on and on. So many different side effects. So we really, really try to get patients off steroids as soon as possible. So two medications that we've used in this situation, if it's more for the skin, one is called dapsone that works well for a lot of different skin conditions. And then the other is one called colchicine that we use. And these we find are a lot safer. Now the dapsone does fall within like a sulfa category. So if that's something that somebody's allergic to, then it's something that we might avoid. But it just gives you an idea that we have a few other options in our back pocket. And then the next few slides, I'm just going to highlight a few different studies and papers that are more on the adult in the adult literature. So one thing that people have looked at is what kind of things might tell us if somebody's going to have a poor outcome or have more complications. So one big area is with the kidney, like how can we predict it? So one is if they have a lot of protein. So your doctor, sometimes they will collect a full 24-hour urine collection where they have you collect every single time you go to the bathroom for an entire 24 hours. And then we measure how much protein is in that. And that, if it's over a gram per day, that can be one that can definitely indicate a higher risk of ongoing kidney disease. And then blood in the urine. So when we say macroscopic, that means you can just see it even with your eyes. So if there's like frank blood in the urine, the hypertension early on can be a risk factor. And then again, if the protein kind of continues even during follow-up. And then in many of these patients, they have a biopsy. And if that shows scarring early on, that's definitely going to be a poor sign. And then the relapse risk for patients with renal disease is up to 20%. So definitely now, we're getting into the higher number. And then progression to end-stage kidney disease is about 11% in this population. And progression to severe chronic kidney disease is about 13%. So again, it doesn't sound that high, but now we're getting into that smaller and smaller number, but just a more severe kidney involvement. And so how do we treat this? So here, again, I have a few studies that actually one of my adult colleagues at Ohio State shared with me. And what we have is really the kidney condition that's the equivalent is called IgA nephropathy. So just like IgA vasculitis, which is anywhere in the body, the IgA nephropathy is more specific to the kidney. And so this picture on the right is what they see when they do the kidney biopsy, where they get a little piece of the kidney tissue, and that's really your filtration system within the kidney. And they can see inflammation there or damage when they look at that under the microscope. And so here, what they found is one of the very first things is actually controlling the blood pressure really well. So some of these medications you might be familiar with, the group is called ACE inhibitors, and an equivalent is called the ARBs, which is a certain mechanism that they work on within the kidney to actually help with the blood pressure. So that's one of the first things, is you need good blood pressure control to have healthy kidneys. And the second is when you start seeing more of that protein, those might be patients that you actually give them really high doses of steroid. And that could mean that we're giving it through an IV at a really high dose. Sometimes that's given weekly or monthly. So there's a few different ways that rheumatologists might decide to give this medication. And so to expand on that a little bit more, which specific medication is going to work here still remains pretty controversial. And so there's this particular study called the Stop IgA Nephropathy trial that was actually published in the New England Journal. And I have the reference for it at the end of my presentation. But what they actually found, they did a very, very detailed, thorough study for a full 3 years. And they tried to see whether they could give one group received immunosuppression and one group did not. And they found that adding the immunosuppression actually did not help too much in terms of the long-term outcome. And so they found that the decline in renal function was not reduced by adding immunosuppression. And one of their treatment options was that mycophenolate medicine combined with a low dose of prednisone. And they said that that might be as effective as using even a higher dose of prednisone, and that they actually had fewer side effects. Another medication that's been used is called rituximab, which you might be familiar with from other types of vasculitis. And really, we just found like single case reports of this medication being used. But again, it's a potential option for those more severe cases if they failed more than one treatment. And so a little bit about this Stop IgA Nephropathy study. They monitored that kidney function and the protein in the urine. They initially started out giving very high dose steroids through the IV for 3 days. This was given at month 1, 3, and 5, and then they followed it up with oral steroids. And then they used a really high dose of immunosuppressive medicine, which is called cyclophosphamide. It's actually a chemotherapy medicine that we use in our most severe vasculitis patients. And so they gave that for 3 months, and then they followed it up by another medicine called azathioprine. The brand name for that is Imuran. You might have heard of that. And then they continued with that from month 4 up to finish up the whole 3 years. And so then they went and actually looked at the two different groups, one group that got this and the other group that didn't. And they looked at clinical remission, they looked at their kidney function, whether they needed dialysis, whether they still had blood in the urine. And the end result was actually that there wasn't a huge difference between the two groups. And interestingly, the group that had the immunosuppression had an increased risk of infection and weight gain, as you might imagine, between the prednisone and the medications. So really something that gives us pause that we have to think, do we just want to blindly treat it or really kind of target it for those patients that have more severe kidney disease? Another study looked at the mycophenolate in a little bit more detail, and they found that there was a long-term protection that was given by this medication to prevent their kidney disease. And they actually looked at a 6-year follow-up of patients after giving them initial treatment for about 6 months. And I have a couple of figures here that I can just explain to you. So in many of our publications, you'll see these kind of images of how two different treatments were compared. And so in the top panel, you're looking at their urine protein and then their urine albumin protein to creatinine ratio. So how much protein they're losing and how it is comparing to their kidney function. And you can see the bottom line that you're seeing is the mycophenolate. And so these patients actually had better, like the protein they were losing in the urine was better when they got treated with the mycophenolate. And then the second one is actually looking at their survival. And so here you can see that the ones in the dotted line here, the control basically means those patients had different, complications. So the one is for dialysis, and the second is as far as doubling their creatinine. So in both of them, the control group had worse. They had a higher chance of needing dialysis, is what they're trying to tell us. So the mycophenolate does seem to be pretty effective. And so I think that would be a good treatment to consider for these patients. So I will just summarize here in the next couple slides. So in summary, we talked about IgA vasculitis, also known as Henoch-Schönlein purpura. This is the most common vasculitis in children, most often seen in boys and a little more common in Caucasians. Usually occurs in winter and spring, ages of about 3 to 10 years old. They usually start out with a very typical rash, which is red, purple, and bruised, and the name for it is purpura. They might have joint pain, abdominal pain, or kidney disease, and it's a self-limiting disease, and a lot of it is just symptomatic treatment. But as we saw, that patients with severe disease may need steroids and other immunosuppressive medications. And it's important that we tell our colleagues that this disease can be life-threatening, particularly if there's pretty significant bowel swelling, bleeding, or kidney disease. And also, as I showed you, the kidney disease and the recurrent form is more significant in adults. And so these are some of my references that you'll have from Kathy. And then I have the second to last is that New England Journal paper that I think was a good resource. And actually, I wanted to highlight the patient handouts that the VF has. I actually reviewed that also, and that's an excellent summary too. So I think that's a great place to start if you're just trying to get some kind of idea about this condition. So I did use that also to prepare my talk. And so this is a picture of our group. When we work with kids, we're able to dress up for Halloween and do all these fun things with all the sick patients that we take care of. So it's usually a fun time. This is our picture from a few years ago where we were Alice in Wonderland, and I am the caterpillar there in the back in green. So yeah, that's what I have, and I'm happy to take any questions.
Okay, thank you, Dr. Sivaraman, so much for that presentation. You can stop sharing your screen now so that we can see your face on the screen.
Sure.
There we are, and it's now time for questions. And make sure that if you ask questions today, they're specific to the topic. And as a reminder, we can't ask Dr. Sivaraman to comment on any of your personal medical questions because she's not your doctor. But we would like to have any questions put in the Q&A box. So look at the bottom of your screen for that. I have a few that were submitted in advance and some that I came up while I was watching you today.
Sure.
The first one came from a patient, and it was, what can be done for abdominal pain and nausea? Is it common with IgA, and when should a parent be concerned that it's something more serious? I know you addressed that a lot in your presentation, but I thought I would let you comment on their question.
Yeah, so definitely, this is something that we do see a fair amount. And like I said, it's kind of that up and down. So early on, we're like, okay, is there swelling? Do they need steroids? Excuse me. But then some kids, you start the steroid, and then when we're weaning down the steroid, the belly pain comes back. Excuse me, I'm so sorry. Now I have the hiccups. So it really has to be individualized. When they're on a high dose of steroid, we have to make sure they're taking it with foods. Do they have an ulcer? And sometimes if we're really kind of in a pickle, we have to ask our GI colleagues for help. And so that's sometimes something that we need to do. Sometimes they need an endoscopy or another ultrasound. So, there's a whole range of things that might be needed. But that's broadly, like, the most important is that, it is definitely a complication that we have to watch.
Okay, thank you. And you take whatever time you need. You've done a great job of getting through that whole presentation with little coughing. I did want to say that since you mentioned that children with IgA vasculitis can have a recurrence, I wondered if those recurrences can happen years later, or are they always fairly soon after they're diagnosed?
Great question. So typically very soon after, because sometimes these kids, they're just in and out of the hospital, sometimes even 3 or 4 times back to back. I have one little girl I just saw last month, and she was in the emergency room like 4 or 5 times. It was spring break. They were traveling, and they just were in and out of the emergency room. So it's usually within those first few weeks, rarely like 6 months or a year out. Anything beyond that, I would say, is very unusual.
Okay, I think that's great for parents to know so that they do know that it seems to be self-limiting. All right.
Yep.
And in some of the social media groups that I participate in for vasculitis, I've seen comments about how one doctor did not take a skin biopsy, so they thought they were not properly diagnosed. Is that necessary for a diagnosis of IgA vasculitis?
It's not essential, but again, I would have to know the details of the case. It's just one more piece of evidence. But the rash, the typical appearance is really, like I said, like a textbook. But if they're not following the typical pattern, that might be a patient that we look. And like I said, it's usually the lower body. So say it's in other areas or it's just not following the normal course, then we would definitely recommend a biopsy.
Okay. And one of the patients in the Q&A box is asking, are there certain foods that you should avoid?
Not specifically. I know that comes up a lot. I think in general, I think the big one, of course, we're talking about is, I think things like the anti-inflammatory diet, which isn't like, has no harm. But I feel like for us, there isn't really any food trigger that we know of that would be causing this.
Okay. And I also wondered, can patients with IgA vasculitis have another form of vasculitis, or is it usually just limited to IgA?
Yeah, that's a great question. So I think if that were to happen, we would probably just change it to the other form. So like I think you were mentioning like micro MPA or something like that, then we would say it looked like IgA at first, but they actually have MPA. So say for like with this, I wouldn't expect lung involvement or other things like that. So I would probably change the diagnosis in that case.
Well, that makes sense. I am an MPA patient, so I wondered that sort of thing.
Yep, absolutely.
There was another question that came in that said, could you comment on vasculitis affecting the bowels and GI system and other forms of vasculitis like GPA or PAN? And like, is there an overlap, or how do you tell the difference, kind of thing?
Yes, that is also, wow, you guys have great questions. So I think the way, like I showed you that slide of all the different blood vessels, like we kind of look at it in that pattern. So with IgA specifically, it's more the tiny, tiny blood vessels so it's inside the actual like intestine that it's the blood vessels that's affected. But and MPA sure could have similar, it's less common, but could potentially happen. With PAN, I think of it more as a medium vessel. So it's a little bit bigger vessels. So it may actually be the blood vessel that's supplying a segment of the intestine, if that makes sense. So it's not the blood vessel inside the bowel itself, but it's a little bit away that's actually sending the blood to the bowel. And so if somebody isn't acting typical, this again with IgA nephritis, where we're like, okay, something isn't right, we often will get like whether it's that angiogram or an MRA or CTA where we're actually imaging bigger blood vessels. And that will help us to say if it is one of the other subtypes. And so, sorry, the question was really more GI involvement. And so it would be a little bit different. Pretty much with all of them, it's usually like that pain, kind of cramping, usually after eating, because that's when the bowel is starting to get active. and more blood flow going there. So those kinds of things are typical. In terms of the blood in the stool, that's also pretty common. Some of them almost might overlap. I've had some where it almost overlaps with like Crohn's disease, like inflammatory bowel disease. I've had a couple kind of in that area almost. So I don't know if that's what the person was asking about. So yeah, that's where things can definitely get a little more in the gray area, where it's overlapping with another autoimmune condition, if that makes sense.
It does, and I appreciate you clarifying that for us. And that is all of the questions that we have for today. So I just wanted to say thank you so much for taking your time to educate us today. And I wanted to remind everyone that this webinar will be published on the Vasculitis Foundation's YouTube channel. There was a question about that in the chat box. So
Sure.
each person that's registered for today's webinar will receive a follow-up email with that link. So then if you want to share it with anyone, you have access to that. We would like to thank the Vasculitis Foundation for, I'm going to share my screen here if I can. Thank the Vasculitis Foundation for their commitment to the medical webinars and patient support, and also, of course, Dr. Vidya Sivaraman. And we so appreciate the time that you've shared with us today.
Yeah, thank you for the opportunity. I'm happy to help.
And as a final word, I just want to say, for those of you that are watching today, there is another webinar on Thursday. I'm pretty sure it's 12:30 Eastern time on bone health. It's going to be a great webinar, and it crosses a lot of forms of vasculitis. So I do think that you should look into that on the Vasculitis Foundation website. And thank you so much, everyone. We appreciate your time today.
Thank you. Thanks for all you're doing.
All righty. Bye.
Bye.